Hello, everybody. Thank you for coming here. I would like to open this session, Surgery in Pediatric Adolescent Gynecology. First, as a host, I would like to welcome you here in Belgrade. I hope the weather would be better today afternoon, tomorrow, and in Sunday, so you could enjoy the best of Belgrade. There is a lot of historical monuments, tourist attractions, cafes, restaurants. People are polite and pretty good speaking, well speaking English, so I think that you won't have any trouble in communication and in enjoying this city. And I hope you'll bring with you sweet memories and come back sometime here in Belgrade and in Serbia. This is the first thing. The second thing is that I should introduce myself. I'm not a gynecologist. I am a pediatric surgeon working at the Department of Pediatric Abdominal Surgery at Mother and Child Healthcare Institute of Serbia. It is one of two biggest pediatric centers, not only in Serbia, but in whole region. But throughout my career, which is not short, it is 2 years to the retirement, I've been involved in treatment of gynecological disorders in urgent surgery and as well in elective surgery. That means in treatment of ovarian torsions, tumors, and ovarian cysts. So I believe I am competent enough to be today here with you. And now I would introduce the other chairman, Mrs. Sylvia Bonsejon, if I pronounced well, from Argentina.
From Argentina.
Sorry.
Yes, hello everyone. I am from Argentina. I am the chief of the section of pediatric and adolescent gynecology in the British Hospital in Buenos Aires. It's a pleasure to be with you today. And in honor of the time, we are going to present the first work that is inpatient disease spectrum and clinical characteristic of surgical disorders in pediatric and adolescent gynecology. Please, you have 5 minutes to the presentation and 2 for question. Yeah?
Okay, thank you. Thank you, Chairman. Thank you, Chairman. Thank you, everyone. I'm Dr. Huang from Peking University, First Hospital of China. It's my great honor to be here to share one of our recent research on the conference. Today, I'd like to discuss about inpatient disease spectrum and clinical characteristics of the surgical disorders in PAG. I have nothing to disclose. As we all know that PAG has enjoyed more than 80 years of development in Western countries, but there is still substantially unfulfilled need regarding specific health issues amongst the children and adolescents with gynecological disorders. This situation in China is even more critical. Under the umbrella of gynecology, PAG is linked to other branches of medicine, particularly surgery, and the objective of our study is retrospectively analyze the clinical data of PAG surgical inpatients in the past 12 years. We'd like to summarize the surgical disease spectrum and clinical characteristics, and also provide PAG data support for future clinical works. In the past 12 years, there were more than 60,000 patients with gynecological surgical diseases were hospitalized, and 512 patients were enrolled in our study. Here's a list of the surgical disease spectrum. We can see that the median age of PAG surgical patients was 16 years old. Adolescents who have entered puberty were the main PAG surgical disease populations. The most prevalent inpatient surgical disease was adnexal mass, followed by 188 cases of unwanted pregnancy. Although the incidence of unwanted pregnancy has been declined this year, but the number is still terrifying and remains a significant public health concern. There is definitely an increased risk for adverse pregnancy outcomes and pregnancy complications, and also our pregnant adolescents will suffer from physical and mental disorders. Abnormal uterine bleeding is one of the most prevalent situations in adolescent girls, but minority requires surgical intervention. Medical therapy is the first-line treatment because for adolescents, maintenance of fertility is paramount.
Yes.
As for the uterine anomalies, most uterine anomalies do not require surgical treatment in juvenile, but obstructive uterine anomalies, which needs to be repaired during adolescence, is extremely rare. In our patient cohort, there were 3 cases of patients diagnosed hemiuterus with a non-communicating but functional rudimentary cavity in the contralateral horn. Because adnexal masses is the most prevalent diseases impact, we discuss it separately. We can see that it is more prevalent in adolescents. The common adnexal masses include ovarian germ cell tumors, epithelial tumors, and peritubal cysts. We found there is a correlation between the obese and the adnexal masses. It's probably because of the work of estrogen, insulin, and insulin-like growth factors induced by the fat accumulation. Under such circumstances, we advocate weight control in children and adolescents. As for the symptoms and the characteristics, the most common initial symptoms is considered abdominal pain. More than 70% of the adnexal masses were torsional, and of which 13 cases underwent adnexectomy for ovarian ischemic necrosis. To maintain fertility and ovarian function in adolescent girls, early diagnosis is necessary. The tumor size of 5 to 10 centimeters carries the highest torsion risk. There is no significant correlation in our patient cohort between the size of the tumors and the malignancy risk. And interestingly, 71 patients accidentally found pelvic mass in physical examinations and proceeded to surgery, which indicates that there is a necessity of the regular gynecological examinations in young girls. In summary, PAG is an essential aspect of women's health throughout their life circles, and we need to strengthen health education for underage women, provide regular gynecological examinations, and promote healthy lifestyles and weight control so as to improve the reproductive prognosis and life quality as adults. Thank you very much, and thank you very much. Thank you very much, everyone. And once again, thanks, Chairman. Thanks to the Congress for the opportunity here. And I'd like to say that Peking University, my hospital, is one of the top gynecological medical centers in China with more than 100 years history. And last year, we just established the first PAG division of the tertiary teaching hospital in Beijing, the capital city of China. And till now, for the whole year, we have already treated more than 1,500 PAG patients, and we hope to continue working on this area to better serve our young girls. Thank you very much. And here is the contact information of mine and my team. Thank you. Thank you.
Any questions? Yes?
Yes, please. Yes. No. Because we need to monitor the pubertal development or any not only the gynecological examination. We can just monitor the do the examination to look if the pubertal development is normal. So we suggested that, but we won't provide this kind of gynecological before the sexual activity. But we just, because there is actually some girls will have the development of height of puberty development problems, but the parents may just not notice that. So I do think we can provide this kind of suggestions, medical suggestions or the examinations, just to monitor the development of our young girls. Thank you.
A question. In torsion, after this torsion, do you fix the ovary or do you let it free in the pelvis? After torsion.
Torsion of the
when you do torsion
yes.
and make the cystectomy, you fix the ovary or you let it free in the pelvis?
Of course, we fixed the ovary.
You fix?
Yes, yes.
In every torsion?
Yes.
Oh.
Well, we try to be, because if it has the sometimes it's just turn purple and dark, and we just have to cut it off. But
Okay. Thank you very much.
Thank you. Thank you very much.
Okay.
Je ne sais, the second one is Jasmine Jaya Singh is here? No. What's your name? Ah, yes.
Yes.
Okay. The second is, the third is Andrews.
Chipolis. Okay.
This one.
Not a problem at all.
This is
I'll
familiar
apologise
to me.
everyone.
Yes.
I think it is Latvia.
Is here?
Lithuania. I don't know.
The guys that made
No, está. Lo que pasa es que no la había.
Rosenheim.
Veamos el tiempo.
Can I put that down? Wait, while you're doing that. It's fine, it'll come up.
She's from Australia.
She's from Australia.
He called it session 2. Sorry, if you'd like to go on, that's fine.
Well,
Oh, there it is.
it's here Andrews Sekoulis. Yes. Have you the presentation? Yes. Perhaps.
Yeah, I'll head off. I'll just put it on the web, on the desktop. I'm sorry, I came in early this morning and I supplied it, just, so I don't know where it's gone.
Perhaps the next presentation while you discharge this?
Absolutely. Can I put it on there? Yeah, there we go.
Okay.
But she has to upload here. There's no another place. So if we don't wait now.
Yeah, it's okay. It's okay now.
Okay. Come on.
Sorry about that. I apologise. I came in early morning to sort that out. My name is Yasmin Jayasinger. I'm a paediatric gynaecologist. I have nothing to disclose. I'm talking about prediction of ovarian malignancy using risk of malignancy indices. Looks like it's on automatic. Benign ovarian cysts are very common in children, but malignancy is more rare. It's important to accurately discriminate between benign and malignant masses to guide surgical planning. Risk scores have been developed to predict malignancy, but they do need further validation in children. So the risk of malignancy index has been used in adult patients, looking at many ultrasound features, menopausal status, and CA125. And there's some work in adults to suggest that there might be some sensitivity for those with advanced stage disease. There are two paediatric risk of malignancy indices. One is that described by Patrick Lowe, and this was in women 18 years and under, and he looked at maximum diameter of the solid component of the ovarian mass, enhancement or flow in a septum or solid papillary projection, and also sex hormone-related symptoms, and found that with a score greater than or equal to 7, there was a greater likelihood of malignancy. Another paediatric risk of malignancy index is the Papich method, and this was initially investigated in females 18 years or less, and he looked at the whole diameter of the lesion, whether there was a solid component on ultrasound, and whether there were positive tumour markers, CA125, alpha-fetoprotein, or beta-HCG, and found that if none of these characteristics were present, then the risk of malignancy was significantly reduced. So the aims of this project were to describe the findings and characteristics of ovarian malignancy in young females aged 21 years or less, and to externally validate the risk of malignancy indices that I've just described, to discriminate benign masses from non-benign, meaning malignant and borderline. So the setting was the Royal Children's and the Royal Women's Hospitals in Melbourne. They're both oncology centres, and this was a retrospective chart review from 1982 to 2019. And we included females 21 years or less and those who had a surgically removed mass. We assessed sensitivity, specificity, negative and positive predictive values, and area under the curve for the 3 risk of malignancy indices. Firstly, to describe the results, there were 460 masses and 83% of them were benign, 4% were borderline and 12% were malignant. The histology of the borderline and malignant masses together, 38% were epithelial, 34% were germ cell, and 25% were sex cord stromal. You can see in the histology, according to age group, that with increasing age, there was an increasing presence of epithelial tumours in green and a decreasing presence of germ cell tumours in blue. In terms of when you look at characteristics of benign versus frankly malignant, we found that maximum diameter of the lesion was significantly associated with malignancy. So if your maximum diameter was over 12 centimetres, the odds ratio was 10.2. Also, if you had a palpable mass, findings of precocious puberty, a solid component, multilocularity and presence of ascites, and elevated tumour markers being CA125, beta-HCG, and alpha-fetoprotein. When we tried to distinguish borderline epithelial masses from malignant masses, the only difference that we really saw was that those in the malignant group were a little bit younger, 14.4 years compared to 18.5, more likely to have solid components and ascites. When we looked at tumour markers in these patients, of those with germ cell malignancies, 92% of them had positive tumour markers. Those with sex cord stromal tumours, 42% had positive tumour markers, and those with epithelial malignancies, 44% had positive tumour markers. But when we differentiated malignant from borderline, 80% of the malignant group had positive tumour markers, and 31% of the borderline group had positive tumour markers. When we when we did the ROC curves, we could see that actually 2 models fared quite well and gave a very good discriminatory value, very good discrimination of benign versus malignant, and they were the RMI2 and the Papich method. The paediatric risk of malignancy index reported by Lowe didn't really fare well, with the area under the curve of 0.619. And I think this is related to the very high specificity for the other 2 models. So in conclusion, we think the RMI2 and Papich method were promising, but this is a retrospective study. And what we really need is a future prospective study, and we're at the moment assessing that, and we're looking at the IOTA assessments using the ADNEX model and simple rules as well. And hopefully that will come up promising. Thank you very much.
Very good.
Apologise.
Well, and what's your name? You don't
Sorry.
introduce yourself.
Oh, I'm so sorry. My name is Yasmin Jayasinghe, and I'm a pediatric gynecologist in Melbourne, Australia.
Okay. Any questions?
I'm so sorry about the disruption today.
One question. Have you in the malignant tumors stratification in the malignant tumors? Intraperitoneal stratification in the adolescents?
Oh, I didn't understand the question. I'm sorry.
After the surgery, when
Yes.
the tumor is malignant,
Yes.
have you a staging of the malignant
yes.
tumor?
Yes. Yes. we stage
Intraperitoneal
all-
only?
Yes, we stage all of them.
Okay.
Yes. Thank you. Yeah. Yeah. That's an interesting question. So generally, our gold standard would be, if we think it's malignant, to do a unilateral salpingo-oophorectomy and staging. With very young patients, because the discrimination between benign and malignant can be difficult sometimes, and there's a lot of overlap in clinical presentation. We go to tumour board first if we suspect malignancy. Often the recommendation will be conservative management in terms of saving the ovary and then going back later to do the oophorectomy and salpingo-oophorectomy and the staging afterwards if necessary. Yeah, that's right. Yeah, complete laparotomy, cystectomy. So if we think it's frankly malignant and we're really certain about it beforehand, we will go and do a USO and staging. If we've got some overlapping features of malignancy, for example, a mass that looks interesting but normal tumour markers, but there's still something about it, we'll still go to tumour board, and often in that patient we will do a USO, still a laparotomy, so we don't open the cyst, do a cystectomy, and then if that then shows that it's malignant, then we feel it's acceptable to go back, considering the low risk of cancer. Yeah. No, just unilateral salpingo-oophorectomy. So, it's a bit varied what we do, to be honest, in the sense that, again, frankly malignant, USO, one-stop shop. The ones where we're not quite sure if it could be benign or malignant, we prefer to be conservative rather than not. But sometimes we will get a frozen section on the day, but we know that frozen sections can miss things, particularly if you've got the tiny little solid thing, it might not show anything and it doesn't help. So our approach is that it's acceptable to do the complete surgery with no spill, and then if it ends up showing a malignancy, then to go back. It's unfortunate, but it's better than taking out the whole thing and a tube if it's benign. Yeah.
Thank you very much. After, because we have no time, Andrews Sekoulis.
Czekoulis,
sorry.
Czekoulis, okay. More familiar. Ultrasound diagnosis and
Ladies
management.
and gentlemen, dear chairman, I'm Andrius Czekoulis from Vilnius University Children's Hospital. Now it's a part of bigger university hospital, and I would like to present the topic about our experiments in management of ovarian torsions in girls and adolescents. I have nothing to disclose. We wanted to show the possibilities and share experience of ultrasound in diagnostics, treatment, and follow-up of acute ovarian torsions in girls. In our hospital, we aim to preserve the ovaries now. This is the main thing. And despite on preoperative and intraoperative findings, we try to preserve. Ultrasound is capable to make a correct urgent diagnosis and differential diagnosis of acute ovarian torsion at the point of care. We do not use CT or MRI in order not to waste time. As well, it's a perfect tool for follow-up. So we checked our data and literature. The main clinical signs of acute ovarian torsion is abdominal pain. They can be morbidity, dysuria, abdominal tenderness, but not in 100%, so only abdominal pain. there are no specific clinical features. On ultrasound, we usually notice increased ovarian volume and often with cystic and solid stromal elements in the ovary and impaired blood flow, shifting of localization. They can be present, but not always. But the combination of two of these signs plus clinical sign usually lead to the correct diagnosis. And the surgery is performed usually laparoscopy. Now there is a table with shift in our surgical treatment. Earlier, about 20-30 years ago, the surgeons were aimed to remove the twisted tort ovaries, but on histology of 23 removed ovaries, they found only hematoma or necrosis and mature teratomas, no malignancies. So we shifted, and for the past 20 years, we do not remove ovaries. We make the torsion only and leave them. And only one ovary was removed on the follow-up when it was clinically proven that it is totally a tumorous ovary. So this is a great shift in our management of ovary torsions. Here are some images, and you see even on the smooth, the very, very torn, twisted ovary, after the torsion becomes not the ovary, but the tuba gains its almost normal color. Here you see in the end. So there are several images on ultrasound. Mainly it's a complex mass in the pelvic region. So the results. From 2005, none of the ovaries were removed urgently, only the torsion without fixation, we do not fix, was applied. On the follow-up, 10 ovarian tumors were removed from these previously torted ovaries with ovarian sparing operation, just leaving the ovary, the healthy ovary. And none of the ovaries were removed for necrosis. The saved ovaries appear to become normal and functional even after ovarian sparing operation due to the tumor. We had no significant complications after the torsion, nor malignancies, nor missed malignancies, or vessel thrombosis, or peritonitis, or anything else. And here is an image of ovary, left ovary post-repeated torsion and excision of teratoma. And it was normal, functional, and good. So this is our conclusions. It is safe to perform the torsion regardless of the level of ischemia, the volume of the affected ovary, or the duration of the symptoms. Just leave the ovary. You have time enough for making decision after. Ultrasound is an effective tool, especially in pediatrics, for diagnosis and for follow-up. And in the preoperative, in the acute phase, and as well after the torsion, ultrasound is fully capable to depict the situation, what is here in the ovary.
A question, doctor? Yes. Stand up, please. Stand up.
My name is Brianna. I work at St Thomas's in London. I follow similar practice to the children and the adults that I see. But my only question is a long-term point, but I don't know the answers, and I don't know if anyone has the answer to it. Is this period of anoxia, what effect does it have on those primordial oversites in the ovary long-term? Do we see an earlier, high incidence early POI, or are there long-term fertility problems in detorting and leaving the ovary without removing it? I don't know if anyone has any experience.
Some of the girls already had their own children. So I think this is the main answer.
Publication that shows that I think it was about 2 years follow-up after the torsion, and they show in about more than 60% normal follicles in these
Yes.
resource also. So that's maybe.
Yeah, it's not. It's more a long-term effect on the oocyte because the primordial germ cell is suspended in meiosis, and it is very, very prone to damage when it's suspended in meiosis. So I'm just thinking, is there an increased risk of miscarriages or chromosomal abnormalities in these women? I'm just curious to know if anyone has an answer.
No, there is no publication about that. But all the girls that grow up, I don't remember that some of them have a problem with have fertility. The truth is that between 9 and 12 years old, the normal ovary could have a torsion because of the flexibility in the pelvis, but the distortion, we don't fix the ovaries in our hospital. You fix the ovary?
We don't.
Because of the adherence after, but I don't. It's a good aim to make a work. You can make one of these, but you need a long follow up. Thank you. Oh yes. Sorry.
I was going to say that I wonder if we can extrapolate from people that have had ovarectomies. So, the people that have had ovarectomies, their age of menopause might come forward maybe a little bit, but not much. And their ovarian reserve might change, but their clinical pregnancy is the same.
There is evidence that even women who have one oophorectomy have a high incidence of early mortality and all the associated POI complications as well, early onset dementia as well.
Okay.
Okay.
Thank you. Which is the
Okay.
next?
We go to the next lecture. Dr. Marina Jakimowska-Stefanowska, bilateral ovarian fibromas in premarital girl with Gorlin-Gold syndrome.
Yes, thank you very much for the opportunity to be part of this Congress. I would like to present you a case report of a girl with Gorlin-Gold syndrome operated in our clinic, University Clinical Center in Ljubljana. So first, something for ovarian masses. We know that ovarian tumors in children are rare, 2.6 cases per 100,000, and only approximately 1% of them are fibromas. Ovarian fibromas in children are atypical. They're benign neoplasms and classified as sex-cord stromal tumor groups. Usually, they're unilateral, and in only 10% from this small group, they can be bilateral. Gorlin-Gold syndrome, it is a rare autosomal dominant disorder caused by mutation of PTCH1 gene. It is multisystemic. It has the person with Gorlin-Gold syndrome has multisystemic development abnormalities. The most important and the most in most cases, it is basal cell carcinoma. They also have keratocyst. It's important that they have medulloblastomas at early age, skeletal abnormalities, and ovarian fibromas. So if in premenarchal girl we saw ovarian fibromas or we have suspicious for ovarian fibromas, we have to check and to think about maybe it can be the first symptom of Gorlin-Gold syndrome. We have a girl, 8-year-old girl, at age of 11 months, she had desmoplastic medulloblastoma. She was treated with intensive chemotherapy, including high-dose chemotherapy, and with supportive analogous stem cell transplant. Currently, she has her first remission about medulloblastoma. At the age of 5, she was first time treated for keratocyst. From family history, we know that she had 3 family members with Gorlin-Gold syndrome, and her uncle died at very early age for medulloblastoma. Additionally, we did genetic checkup to the girl, and we found out that she also has this syndrome. She was going to regular ultrasound checkups and MRIs, and at once, at age of 8, we found out that we revealed free abdominal fluid and lobulated soft tissue masses of both ovaries with positive Doppler signals. The tumor markers were negative. So we decided to perform explorative laparoscopy, where we found out some free fluid and bilateral enlarged ovaries, multiple solid tumors, smooth surface, and whitish. We were actually a little bit surprised that they were so big and large, and we were expecting more normal ovarian tissue. But when we saw this picture, we decided to talk intraoperatively with the parents to ask what do they think about annexectomy or not, because ovaries are both enlarged, and they were not sure if they will agree annexectomy. So we decided to take ovarian biopsy and free fluid sampling. Why ovarian biopsy? Because we knew that she has Gorlin-Gold syndrome, and we knew that in Gorlin-Gold syndrome it is probably benign pathology. So yes, the histological result was that she had fibroma, and cytological examination revealed no malignant cells. 1 week after the laparoscopy, we performed laparotomy, and we did enucleation of all fibromas, one by one, each, leaving the piece of normal ovarian tissue on bilateral ovaries. Histologic confirmed multiple ovarian fibromas without necrosis, without atypia, and with mitotic activity up to 10 mitosis. So in our case, considering the young age of the patient and presence of Gorlin-Gold syndrome, we decided for conservative operative treatment. We were right, and control MRI 5 months after the surgery, and regular ultrasound of the abdomen didn't show any signs of relapse. So as a conclusion, I can say that ovarian fibromas are benign tumors and are rare in children. But in patients with Gorlin-Gold syndrome, even if the ovaries look like disaster, it's better to think, it's good to think that these are benign tumors and try to do preservative operation. So we have here one video, short video, to see how it was. It's shocking for us when we saw it for the first time. So we have to.
What a mess. I would consider frozen biopsy in these cases.
Okay, thank you very much.
Any questions? There? Up. Stand up, please.
Hello, it's Nauta.
Justine.
A question. So there was no sign of relapse on MRI, but what about the ovaries? Do they look normal?
Yes,
Sorry.
normal. She was 8 years old, so they saw that there is presence of normal ovarian tissue, not like big normal ovaries, but this part that we saw. It was the good thing that we left the hilus of the ovary. So these are all outside.
Did you consider a frozen biopsy in the surgery? A frozen biopsy, sorry.
Frozen section or
Yeah.
biopsy? Actually, no. But here we did because we knew that it is Gorlin-Gold and the tumor markers were negative, and in Gorlin-Gold it's mostly benign
Yes.
tumor fibromas. That's why we performed.
Okay, thank you very much. Very
Thank you
good.
very much.
The next presentation, Madame Li Ying-sun, detection experience of a gene mutation for patients with McCune-Albright syndrome from cases reports. Yeah.
Good afternoon, ladies and gentlemen. My name is Gao Huihui. I'm from the Children's Hospital of Zhejiang University of Medicine. Today my topic is the diagnosis experience of gene mutation for patients with McCune-Albright syndrome. Firstly, let me introduce my case. She was a 7 years old girl. Her chief complaint was vaginal bleeding for half a month. Half a month ago, the girl was found with vaginal bleeding. The volume is little. No itching, no smell discharge, no injury, and no vaginal foreign body. After the physical examination, we found the breast development was tender stage 2. Public hair was tender stage 1, but we found the estrogenization of the hormone and the white vaginal discharge. And at the same time, we found a covalent marcus on the right tract. Then the ultrasound was done. We found the uterus was large and the cervix is about 2.8 centimeters, and the thickness of the double layer endometrium was 0.83 centimeters. And at the same time, we found the left accessory area had a cystic mass about 4 centimeters. And in the blood test, the sex hormone showed that its estrogen was very elevated, and the FSH and LH is low, and the tumor markers are normal. So what will be the diagnosis? From the case history, we found she was a pre-puberty girl with vaginal bleeding. So the possible reason may be precocious puberty, vulval vaginitis, vaginal foreign bodies, or tumors. After the physical examination, we think maybe the real reason is precocious puberty. And then after the ultrasound, we found the ovary cystics. So the clinical features of the patient is precocious puberty and the ovary cystics. So what will be the real reason for the girls with precocious puberty and ovary cystics? This is a girl from the previous study. She was 2 years old and present with 3 months of breast development and rapid growth. Examination showed tall stature, tender stage was B3, and single covalent patch was noticed. Ultrasound showed bilaterally enlarged ovaries, and the girl was diagnosed as precocious puberty of the original orange was diagnosis, but finally repeated image showed normal right ovary and a large left slide ovary tumor which was excised. Another case. This was a 14-year-old female patient present with complaints of irregular vaginal bleeding and the apparent abdominal swelling. Her breast development was at stage 2 and the public hair development was P2. Ultrasound revealed a cystic mass of about 10 centimeters. Finally, she was diagnosed as Van Wyck-Grooms syndrome. Remarkable improvement of the symptoms were observed after 1 month of the hormone replacement therapy, and unnecessary surgical treatment was avoided. And we had the third girl. She was a 16-day newborn with ambulous genitalia, was present in the clinic. The baby presents with vaginal bleeding, and for months, we also found the cystic lesions. Finally, she was diagnosed as congenital and renal hyperplasia. So to our case, she had precocious puberty and cystic ovaries. The thyroid hormone and the renal hormone was normal. Tumor markers was normal. Estrogen was elevated. FSH and LH were low. So does she have a tumor or Michael-Albert syndrome? So finally, she received laparoscopic exploration, and the gene sequencing result GNASG mutation. So the final diagnosis was Michael-Albert syndrome. So what is the Michael-Albert syndrome? Michael-Albert syndrome is a real disorder present along a broad clinical spectrum. Disease arises from somatic activating GNAS mutations. Patients present clinically with a variable combination of fibrous dysplasia of both covalent sky markers and hyperfunction endocrinal patients. So the ovary activating is the most common endocrinal patient in girls and women with these problems, and precocious puberty is very common among girls. So what is the relationship between the Michael-Albert syndrome and the PAG problems? So I think this is a very good research from America, and 39 women with these problems were included in this study. The results showed abdominal uterine bleeding affected 77% of women, and infertility affected 43% of women, including 2 women who developed primary ovary insufficiency. And there is no clear association between pregnancy and poor skeletal outcomes in this population, but it told us women with these problems report a high prevalence of gynecological problems and reduced fertility. So, previous study from the PAG, and they showed Michael-Albert syndrome has a close relationship with the prevalence of the PCOS. And recently, studies also showed that Michael-Albert syndrome has a relationship with tumor, for example, breast cancer and cervical cancers. So the challenge to us may be, first, how to diagnose patients with ovary cystic and precocious puberty accurately and earlier. Then second, how to achieve multidisciplinary management for patients. The third, how to achieve whole life care for the girls. So I think cooperation is very important to solve the problem, because we need the pediatrician, gynecologist, endocrinologist, and the scientist. Thank you for your attention. Thank you.
Thank you. Any questions, please?
That is a very good question, because different people have different ideas. It is very difficult for us to diagnose this problem, especially when we need to do the gene sequencing, but the detection of blood test is very low. Sometimes we need to do the surgery, but you need to have a talk with the parents, because not every girls will have the problem with mass, maybe not mass. So I think we should talk, and I think this problem has 3 clinical features. If she has these problems, maybe you should do the surgery.
Because in our experience, the blood tests are useless because there is usually a tissue mosaicism in this syndrome, and more frequent genetic tests are positive when we use fluid from the cystic lesion, ovarian cyst, than when we send the wall of the cyst to genetic evaluation.
Okay. Thank you for your.
Thank you.
Does this mean that we don't have to spill it?
Just take small piece of the.
I mean, are there risks?
You don't have to
when we
remove the
spill it?
cells completely, yes, because just demonstration is successful and results in a drop of estradiol and spontaneous resolution of the cyst. Or to have this genetic confirmation of the syndrome, we know that the fluid taken from the cyst is much more reliable material
Okay, don't you treat first if you suspect the McCune-Albright syndrome before surgery? Don't you try to treat the cyst with the treatment, the hormonal treatment?
Of course.
Because no, it's not mandatory, the surgery in these cases, because she respond to it. Okay.
But when the girl is young and the cyst persists for some weeks and the levels of estradiol are extremely high, we have some patients that had not 700 picograms of estradiol, 1,000 picograms of estradiol, yeah, not the levels, and there were and they didn't answer to attempts of pharmacological treatment, yes. So usually we don't perform surgery when the first cyst appears.
Yes.
But when the recurrence happens in a patient and there is no spontaneous resolution of the cyst, especially in prepubertal children within the following weeks, 2, 3, so we decide to perform the surgery to confine the diagnosis of McCune-Albright syndrome. But of course, not all these patients with recurrent functional cyst in prepubertal period have McCune-Albright syndrome.
Okay, thank you very much. Thank you. Next.
Thank you. And shall we go to the last lecture for today here? Madame Karina Matusiak, undescended ovary complicated by a cyst with contralateral tubo-ovarian agenesis.
Hello, my name is Karina Matusiak. I'm a gynecologist. I work in PAG clinic in Children's Memorial Health Institute in Warsaw, Poland.
Yes.
This is my status.
No.
I would like to present the history of Carol, which has started 17 years ago when she was referred to our clinic with prenatal suspicious of left ovarian cyst. She was 6 weeks old then. Her physical examination was normal, and on transabdominal ultrasound we found a normal uterus. We didn't see the right ovary, and on the left side there was a complex mass about 4 centimeters in diameter. We performed some blood tumor markers and referred the girl for scheduled operation. During the procedure, the surgeon asked for consultation because he found uterus, but there was no right adnexa, and he also didn't find the left adnexa situated typically and connected with the uterus. And instead of this, he found a left-sided complex mass, which was hanging on a very long fallopian-like structure. It originated from the left pelvic wall, and it was quite high above, on the level of the pelvic brim. He decided to remove the complex, and the histopathological examination revealed ovarian tissue with old necrosis, calcifications, hemorrhagic masses, and a fallopian tube. Her control pelvic ultrasound was normal, FSH almost 60 units. She had a normal karyotype. She was coming for a regular checkup, but with time we didn't observe any signs of sexual maturation. When she was 10 years old, we performed pelvic and abdomen MRI, which revealed any ovarian tissue. Below you can see her hormonal profile. When the girl was 11 and a half, we decided to introduce estradiol therapy, and about 1 year later, she got menarche. Then we introduced estradiol with the drogesterone. So our diagnosis was right adnexa agenesis, undescended left ovary with an undescended fallopian tube. An undescended ovary is a common congenital condition characterized by the presence of the superior adnexal pole above common iliac arteries. It can be isolated or more often associated with uterine anomalies. Let me remind that starting from the 3rd month of fetal life, the ovaries descend guided by the gubernaculum attached to the inferior pole, and during the immediate postpartum period, they complete the descent into the ovarian fossa. The underlying mechanism of ovarian malpositions remains unclear, but it has been suggested that it might be due to lack of caudal descent or growth restriction of a specific portion of the genital ridge. As the incidence is higher in the presence of uterine anomalies, it can be a multifactorial polygenic process at the end of the 2nd gestational month. Most patients are asymptomatic, and usually this ovarian malposition is discovered among adult women during an infertility workup. However, some anamnestic key features could direct the physician to think about this condition, like cyclic abdominal pain above the pelvis. And when complications occur, such as torsion, they usually lead to acute abdomen, and then a surgery let us make the ultimate diagnosis. Nowadays, the laparoscopy is considered the gold standard for the diagnosis of undescended ovary. When we consider imaging tools, the MRI should be the first choice, as it is the most sensitive imaging modality for the evaluation of Mullerian and urinary structures. Moreover, Ombelet suggested performing MRI after ovarian stimulation with clomiphene citrate. An undescended ovary is a normal developmental variant of the ovary and does not require removal in the absence of any concerning pathology. When it coexists with non-communicating undescended fallopian tube, like in our patient's case, the fallopian tube should be removed to reduce the risk of ectopic pregnancy, which is common in this population. Another problem in our patient's case was the lack of right adnexa, which is also rare, and the proposed etiologies are developmental defect or an early torsion. We can use the same diagnostic tools as in the previous problem, and our patient's history confirms the diagnostic value of a surgery. So an undescended ovary is mostly found incidentally among adult women during an infertility workup, whereas when complicated by a cyst or tumor in children, it is a developmental condition rather than a malformation, but with an increased risk of ectopic pregnancy or infertility. Although both conditions are very rare, it is worth to remember about them while having problem with finding an ovary during an ultrasound. Thank you.